Thank you, Bill. Can you guys hear me? Okay. Okay. Thank you, Bill, Carla, and Susan for the great conference and the invitation. Invite me every year, please. So, my name is Akram Zaaqoq. So I am one of the critical care. I'm a CV intensivist most of the time since I finished my fellowship training, and I'm the medical director for ECMO at Medstar. So I came to you guys from Washington, D.C., the nation capital. So these are my disclosures. So my objectives for this talk, the current situation with the management of ARDS, with all the advances that we know, the mortality of ARDS remained the same. And my aim is to highlight some of the gaps and the opportunities in the current management. And I hope by the end of this talk I can convince you and give you the evidence to convince your teams to utilize ECMO early on for ARDS. So from the previous talk, when I am a Superman, no, I'm joking. I am not going to, I'm going to go over a lot of scientific literature to highlight this topic. And some of it might be basics for you guys, and some of it might be some new updates. So ARDS is well described as being a heterogeneous syndrome. So it's non-cardiogenic pulmonary edema. It reduces the oxygenation, so it's acute hypoxemia. And it reduces lung compliance and can happen due to a variety of etiologies. Can happen due to pulmonary causes, pneumonia, COVID-19, other form like aspiration pneumonia, but also can happen due to extra pulmonary etiologies, with the most common you've seen probably is the transfusion-related acute lung injury. So these are the criteria, the current criteria that we are using for the clinical diagnosis of ARDS. It's the Berlin criteria adopted 2012. And this is different from the previous criteria of ARDS in 1994 because it highlighted some factors. So what is the timing of ARDS within 1 week? How we do diagnose non-cardiogenic pulmonary edema. So we don't need a SWAN or pulmonary artery occlusive pressure. We can use clinical markers or echocardiography. And added also decrease of severity that did not exist before and incorporated the mechanical ventilation in this criteria. But then there is a Kigali modification for this criteria because what happened in the low-income countries, they don't have access to all of these criteria that you see on the screen. So this is some sort of modification to low-income countries that they don't have arterial blood gas, they don't have chest X-ray, they don't have even mechanical ventilation. So they remove the PEEP and they use O2 saturation to the FiO2, and they incorporated ultrasound as a diagnosis for the chest imaging. And this paper was published in the Blue Journal. Okay, so ARDS, so we talked it's a heterogeneous syndrome, and by heterogeneous syndrome that it goes into phases. So the acute phase is the exudative inflammatory phase, and then proliferative phase, and then fibrotic stage. It is similar to any kind of inflammation in any part of the body, and I'm sure most of you during COVID experienced this with the patient care in severe form. So the first phase, which is the exudative phase, once the injury hit the lung, The alveolar macrophage trigger inflammatory cascade to recruit more cells, increase the permeability of the alveoli, and the alveoli get filled with fluid. Afterwards, into the proliferative phase, the body is trying to restore the normal structure, and by doing so, bring more of fibroblast cells to build that infrastructure. And then the fibrotic phase, which is the last phase, and this happened in context of mechanical ventilation, the body fail, and those infrastructure become replaced with a fibrous tissue. This paper was one of the landmark papers, in my opinion, was published in 2016 about epidemiology for ARDS. So it was 459 ICU, 50 countries, 5 continents, 4 months in the winter of 2014, estimated the incidence of ARDS by being 10% of all ICU admissions. Most of those cases are moderate ARDS by Berlin definition, but the mortality of ARDS decreases as the severity increases. This diagram here, it will show you the trend in the mortality of ARDS. This was a systematic review, and they looked at the data. Now, I tried to exclude COVID a little bit from the slides because it's still work in progress for us to understand the science. But this paper, it's a systematic review, published in the Blue Journal, and they looked at the trend of the mortality of ARDS. And what I want to get your attention to is the black dotted line. This is observational studies. The black line, is solid line, is observational studies. The dotted one is randomized controlled trial. By the first glance at the line, you will see early on in the 80s and probably early 90s, the mortality was relatively high in ARDS patients, and the mortality in the observational studies were higher than the randomized controlled trial. Afterwards, starting from late 90s and 2000, both lines come together. Mortality is around 40%, and this is with all the interventions that I'm going to go over it quickly. So, we have to look into the past to understand how the future going to be. So early on in the early 80s or maybe in the 70s, mechanical ventilation was essentially used to keep the patient alive. So high tidal volume, high PEEP, and all the aim is to maintain the oxygenation. And this is the early trial of ECMO. It was in 1979, and I'm presenting this trial to show you that the mortality for the conventional ventilation group and the ECMO group was both very poor. So it was 40 patients, no one survived. Of course, there is a caveat from the ECMO standpoint that they use VA ECMO for ARDS management. Anticoagulation was not, cutting edge as we have. Technology was early on. But all these patients, they died from decrease in the lung compliance and progressive reduction in the gas exchange. Okay, so what happened then afterwards? CT scan. So the CT scan, with the discovery of CT scan and scanning patients with ARDS, we start to understand that this disease is heterogeneous disease, heterogeneous syndrome, but also it affects the lung in a heterogeneous way, meaning the concept of the baby lung which is referred to the remaining functional part of the lung in ARDS. And that sparked the scientific community to start looking differently at the mechanical ventilation. So then we start to understand that mechanical ventilation is not benign intervention, and it carries risk. It carries the risk of the ventilator-induced lung injury by frequent opening and closing on the lung at low tidal volume that will induce inflammation in the alveoli, but also by hyperextending the lung will induce barotrauma, pneumothoraces. And this effect of the mechanical ventilation is irritating to the lung as the same as the underlying ARDS. Not only that, it's actually propagate beyond the lung because of all these systemic inflammatory markers can go into the body and can induce multi-organ failure and then lead to the patient demise. So with that, we start noticing to do less is probably more when it comes to the mechanical ventilation. And this paper, of course, for Gattunini highlight some of the changes in the ARDS management. So in 2000, this the Artsnet trial shows if randomization of the patient between two groups, low tidal volume with a lower plateau around 30, low tidal volume 6 cc per kg of the ideal body weight versus the 12 cc per kg of ideal body weight and plateau around 50. The low tidal volume group, they have better survival. The study stopped early because the result was just clear and obvious. When it came to the PEEP titration study, using PEEP titration, either low versus high PEEP titration table for ARDS patients, it did not show mortality benefit for those patients. In matter of fact, what this paper shows actually lung recruitment in the ARDS patients is detrimental and increases the mortality at 28 days, with more tendency towards pneumothoraces and requirement for chest tubes. And this paper in the New England Journal of Medicine that utilized using the esophageal manometer for titration of PEEP was not, when it comes to mortality benefit, was not really superior to the traditional PEEP table that we've been used. But what I liked about this study that shows you even we're probably on the lower end when it comes to PEEP utilization for those patients. So the bottom line from those three PEEP trial, and I have my friend here, Eric Kreiner, is going to speak about ventilator management in ECMO patients tomorrow, and he's one of the esophageal balloon experts. So probably we are on the lower side, but that's fine. We don't really need higher PEEP to maintain the lung open. Prone positioning also shows mortality benefit on ARDS patients. Proning patients for 16 hours shows superiority and make patients survive. In subsequent analysis of the driving pressure of the ARDS data, shows the driving pressure, which is the difference between the PEEP and the plateau pressure, also associated with better survival on those patients. So usually we aiming to a PEEP, as you can see on the diagram on your right-hand side, you see the plateau probably 15 or less is actually better for those patients. And now this become part of our like standard management for ARDS. And this is just subsequent analysis for Artsnet patient population. Okay, ECMO. I think we all agree in this room that ECMO is safe and beneficial for patients with ARDS. It is safe. It's, in matter of fact, if we prevented or denied for patients who are needing an ECMO, that associated with higher mortality. I'm going to show you a study on this. But those are like 3 studies from our experience with CESAR trial, which was critiqued that the patient was transferred to an ECMO center, but not all of them was put on ECMO, running into the H1N1 studies, and then the Aeolia trial. Shows ECMO work, ECMO save for a patient. They did not, especially the Aeolia trial, with many caveats, did not show mortality benefit if you just look at the conclusion of the study. This is from COVID-19. A study was done in UK, and it's 100, almost close to 100 hospitals, and they transfer, and 100 hospitals were included, and they sending patients to 2 ECMO centers. So what they did, they looked into the patient who end up on ECMO versus patients, they matched them from the whole cohort where people who are ECMO candidate, but they did not end up on ECMO for whatever reason. And as you can imagine, the mortality in the ECMO group was significantly lower than the people who are qualified for ECMO, but they did not get ECMO. So that's something just for consideration, that ECMO actually saves life. So this is the past, and this is what we know so far, and that's what we've been doing for our ARDS patient management. And with everything we've been doing, mortality of ARDS remain close to 40%. So low tidal volume ventilation, prone positioning, PEEP titration, even like neuromuscular blockade, you name it. With all these, the mortality remain close to 40%. So what are we missing? And I think this is the part that we can talk about it more. So what we know actually mechanical ventilation is not only affect the lungs, it's not causing ventilator-induced lung injury, it's actually affect the diaphragm too. So diaphragm over time in a patient like who is sedated completely on controlled mechanical ventilation, they start experiencing diaphragmatic dysfunction. And if any of you, I do remember one of the patients I took care of in UPMC when I was a fellow, and by the time we get him through his ARDS, he was severely deconditioned. He was, of course, strict. He was stuck on the mechanical ventilation, and he remained in the hospital for 6 months, acquiring all kinds of infection and complications. So mechanical ventilation will cause some diaphragmatic dysfunction also, and make weaning of those patients afterwards is difficult. This study here, they did something interesting. So what they did, they gave a patient, they followed the ARDS recommendation, 60 cc per kg, low tidal volume, and they scanned the patient under the scanner, look at it. 30 patients, 20 patients were, they call them like hypoinflation arm, and 10 in the hyperinflation arm. What they found is actually 6 cc per kg because of the differences in the baby lung size. Sometimes 6 cc per kg is a little bit too much for the patient who are with severe ARDS. If they have small proportion of the baby lung. So you're giving 6 cc per kg, 6 cc per kg could even be more traumatic in some patients. What about plateau pressure? This study, they looked into the association between the plateau pressure and tidal volume. They've done very robust in ARDS population that were enrolled in ARDS network trial. And they did very robust analysis trying to delineate, the relationship between the tidal volume and with the plateau pressure. And what you can see from this diagram that even 30 centimeter water plateau pressure could be also traumatic to the patient lung. Maybe the cutoff is lower, maybe like around 25 or something like this. So if the tidal volume is 6 cc, could be too much, so what's the lower limit for the tidal volume? And if the plateau pressure of 30 or 35 cc, 30 or 35 centimeter water is too much, so what is, the lower and the safest cutoff? This study shows that 6 cc is probably okay, but if you look at the line, you will see even trend towards lower tidal volume. It might be beneficial to the patient. Mechanical power is a concept was brought by Dr. Gattunini, and it is the amount of energy that get delivered into the lung by the mechanical ventilation. And this is multiple factors. It is how much tidal volume you give to the patient, so how much air you push into the lung, and what is the rate, and how fast you give it. So it calculates the overall energy that the mechanical ventilation deliver into the patient lung, and it is effect on the lung healing process. So what do we really need? So we need, for those patients with severe ARDS, we need to maintain adequate gas exchange. That's one of the goals. And we need to allow the lung to heal. We want to reduce the ventilator-induced lung injury, let the patient breathe spontaneously, and to get them to do more physical therapy and mobilize as this process goes on. So now we know there are different, in addition to the heterogeneity of the disease, so it goes through different process and affect the lung differently. Now we know that actually also different phenotypes of ARDS. So it's getting very complicated, and really to deliver a personalized approach for those patients require a lot of sophistication. So there is hypoinflammatory type and hyperinflammatory type. And the interventions that we do in those patients, they have different responses, and their recovery is completely different. Why do we need the patient to breathe spontaneously? Breathing spontaneously comes with some cons and comes also with some issues. So breathing spontaneously will allow the better distribution of the gas throughout the lung. It will engage the diaphragm, and of course will allow us to reduce the sedative use with the patient, to move and walk. That's why all the, potential benefit from spontaneously breathing. But one of the things, or multiple things also we have to watch for once we allow those patients spontaneously breathing, that the concept of patient self-inflicted lung injury. So the patient will have tendency to have a larger tidal volume that can cause also further damage of the lung. This is, of course, if they are on mechanical ventilation. So that's what I'm trying to get you at, where we would like to see patient on ECMO who is awake and who's spontaneously breathing, and he can do physical therapy, and we can discuss and talk to him. We can communicate to his family. What is the benefits of the awake ECMO? This one of the initial experiences with the COVID-19 where they used, where they had a great survival. It came from Rush University, and they have great survival. And what they did, if you look at the diagram down there, they extubated actually all their patients, and the survival to decannulation was close to 80%, and 75% actually they made it out from the ICU. So great survival with awake ECMO. And also, this study was done, this is not COVID, this is pneumocystis pneumonia, patients with HIV, and also awake patients who are on ECMO, and actually they are not on the mechanical ventilation. They have the better outcome for those, for these patients. This study was an animal model, sheep on put on ECMO, and the authors of the study found just by using ECMO, actually we can control the gas exchange, and we can control the breathing of those animals. This is a case report. So this was about a patient with a COVID-19. It came from L'Appetit in Paris, Matteo Schmedet. They put this patient, was a case report published in the Blue Journal. They put the patient on ECMO directly from high flow nasal cannula. Patient stayed on ECMO for almost 40 days. And he was transferred to a rehab facility afterwards. They used two configurations. They used FEM jugular, and then during the ECMO run, they had to switch to FEM ECMO because just the infection. Patient has bacteremia, and they had to change the cannula site. But the description that they wrote in the paper, it was fascinating actually, because on day 18, that's what they wrote. On day 18, patient was able to stand up with assistance. He has oral feeding, maintained throughout the ICU stay. He has social interaction by phone or face with his relatives. More importantly, he was informed daily of his health status, medical decision, and was able to express his preferences. And this is my last slide. Also, multiple case series about patients who were on ECMO without mechanical ventilation. So, in conclusion, ARDS remain challenging disease, syndrome, and with all the advances we've done so far, really we didn't make much progress, and it is time for us to consider a different way for those patients. And the proposed approach go directly to the ECMO, bypass the mechanical ventilation, and allow the lung to heal. These are my references, and I'm happy to take any questions.